My name is Lena. I'm co-chair with Angela here. We're very happy you're all coming to join us this morning on an early morning of a very busy convention week. It's the NACFC disclaimer. We have no disclosures. This is our beautiful Braga, who will be speaking to us hopefully at the end. And then we will have a nice panel of speakers today. Our focus and objective is to talk about the cost of CF. It's not just financial, it impacts daily lives, as you know, and it's multifaceted. So we want to just highlight that the concerns we have as caregivers, as well as family members and patients, and then also address some ways that we can find solutions and hope.
So Cameron McKenzie is our first speaker. She's a pediatric pulmonary clinical pharmacist practitioner at the University of North Carolina Medical Center in Chapel Hill. She primarily cares for patients, thank you, with CF and interstitial lung disease. She received her doctorate of pharmacy degree from UNC Eshelman School of Pharmacy in 2012 and completed her PGY1 and PGY2 residency training at the Medical University of South Carolina, Charleston.
Okay, thank you. So we're going to start off today talking about everyone's favorite topic, medication access. So we're going to talk about insurance and how different insurance structures impact medication access, and then also go through a not all-inclusive, but tried to make it pretty complete list of resources that we can potentially use to help our patients with these costs. The disclaimer again, and just one prior relationship. So objectives really twofold. We're going to start from the beginning and go through some insurance terminology, and then talk about the implications on some different insurance structures for medication access. And then we'll spend the second half talking more specifically about financial assistance available for people with CF, both for specific medications and more holistically. So let's first start with terminology. And some of these are things that every time I think I know what these mean, something changes. So first, deductible. So this is the amount that has to be paid before the insurance begins making payments. This can vary between insurance plans, but for example, this is why often in January we see someone's inhaler that used to be a $40 copay costing them $300, because every insurance year the deductible resets, and so patients have to pay the entirety of the cost until they meet whatever that deductible threshold is for their plan. Coinsurance and copayment get a little confusing. So coinsurance is where there's a percent of the total cost that a policyholder pays for covered services. Copayment is where that's a fixed cost. Some insurances use both depending on what the service is. A lot of times we see copayments for medication, so your $20, $30 copay, but increasingly we're seeing coinsurance, particularly with really expensive medications. Out-of-pocket maximum, exactly what it sounds like. It's the maximum amount that a person can spend in a coverage period, after which the plan is supposed to cover 100% of covered services. The out-of-pocket maximum was capped with the Affordable Care Act, and they reevaluate that cap every year, but it's right now in the neighborhood of $19,000. And then coordination of benefits, which I don't actually think is coordination, but that's different, is the process that insurance uses to determine how benefits and claims are handled when a patient has more than one plan. So this is what happens behind the scenes to decide that Plan A is the primary and Plan B is the secondary. Again, it's not always super clear, but that's what's supposed to happen. So in case those terms weren't confusing enough, we have, in recent years, added in copay adjustment programs. And these are things that are specific to medications, but impact how financial assistance is or is not applied to some of those things like deductible and out-of-pocket maximum. So copay accumulators are the first type of these copay adjustment programs. And these really exclude copay assistance altogether from applying to the patient's deductible and out-of-pocket maximum. These programs take the stance that out-of-pocket should truly mean out of the patient's personal pocket. And so even though patients can use those programs, anything that's applied doesn't go towards that. And so the insurance company is happy to take it, but they're still going to ask for it from the patient too. copay maximizers are slightly different in that they establish cost sharing that really aims to maximize using the manufacturer copay assistance. So it doesn't necessarily shift the cost as much back to the patient, but it does shift the burden of the coverage away from the payer. And then alternative funding programs, or AFPs, which I feel like is a bad word these days. These are also referred to as specialty carve-outs. And really what these do is they exclude particular medications or even whole medication classes from the prescription drug benefit. And then the member is directed to work with this alternative funding vendor to figure out either financial coverage through the manufacturer. In some cases, they will help the member apply for coverage as though they are uninsured because they take the stance that the medication is not covered by the plan. These are most often used by smaller employer-sponsored plans, and they're marketed pretty heavily. If you just Google alternative funding programs, you find some really interesting marketing materials. But these are increasing in use, so definitely something we need to be aware of. All right, so we're going to attempt to go through an example because I feel like that's a lot, and trying to understand it in practice can be more helpful. So although this is probably not the most realistic situation for our people with CF and for our medications, for simplicity, I picked simple numbers. So in an example where we have a patient who has a $2,000 deductible and a $4,000 out-of-pocket maximum, a medication cost of $2,000 per month, which I know we don't have any of those, but we can hope, and then a copay assistance program that covers $2,000 per month and a maximum of $12,000 per year. So in a traditional plan, in January, the patient's deductible has reset, and so in January, they're going to be responsible for the entirety of that $2,000 per month cost. The payer isn't paying anything, the copay assistance would pick up the $2,000 per month. After that, because this is a traditional plan and that copay assistance gets applied to their deductible, the patient has met their deductible, they didn't actually have to pay it themselves. And then beginning in February, the payer would pick up their portion of the cost. The copay assistance would pick up the rest at $200, and that would continue until the end of November. Then in December, the payer will pick up the entirety of the cost, and at the end of the year, the patient hasn't paid anything out of pocket, and the copay assistance has only paid $4,000. So most of the burden of coverage falls to the insurance company, which makes sense. With a copay accumulator, the goal really is to shift the burden away from the payer. So in the first 6 months of the year, copay assistance would be used, maximizing what we can use from the manufacturer-based program. $2,000 is covered entirely by the copay assistance program, but in June, because we've now used the $12,000 maximum amount per year, and the patient themselves hasn't paid anything out of pocket, in July, they are now going to have to pay $2,000 out of pocket to meet their deductible, and then for the rest of the year, it becomes a cost share between the payer and the patient's out of pocket because we've at that point used all of our copay assistance. So you can see in this example, we've shifted $3,000 of that total $24,000 cost to the patient. We've shifted half of it to the copay assistance, and we've shifted a substantial portion away from the payer. So it's still the same total amount, but who is paying is drastically different. So if we use the same example, but talk about a copay maximizer, the goal of copay maximizers is really to maximize the copay assistance that's available from the manufacturer. So in this case, what it does is it looks at the total maximum amount that can be used per year, and it divides by 12. So since I use nice numbers, we get the copay assistance paying $1,000 every month and the payer paying $1,000 every month. In this case, again, the patient isn't going to have more out-of-pocket cost, but it does shift that burden away from the payer, which means we're using more copay assistance from manufacturer-based programs. So how common are these copay adjustment plans? Unfortunately, the answer is more and more every year, but it does really depend on where you live and where the insurance plan is based. So I am fortunate to live in a blue state of North Carolina, where some of these programs like copay accumulators are illegal. But even for us, we have patients who have plans that are not based in our state. So I have patients who have Blue Cross and Blue Shield of Texas. And so because that's a Texas-based insurance plan, I now have to consider what is or isn't allowed in Texas. And so even if you're fortunate and in one of these states that's blue and has some legislation, you're not entirely exempt from this. And you can see in this graph, as you go from green to yellow to orange to red, the percentage increases, with the red states having more than 3/4 of their patients' plans with copay adjustment components. Okay, so now I've told you all of the really bad things, so let's talk about how we can help with this, because otherwise I don't want you to leave here in that state of mind. So there are really 3 primary buckets of medication access assistance. There are manufacturer-based copay programs, and these offer patients with commercial insurance financial assistance, usually for specific medications, after the plan has paid their portion of medication coverage. These almost always exclude uninsured and federally insured patients by law and may or may not have income criteria. Currently, most of them don't, but there are times where that comes into play. The nice thing about these is that they can usually be adjudicated or run and processed at the dispensing pharmacy, so the cost can be picked up in real time as opposed to patients having to pay out of pocket and get reimbursed. Manufacturer patient assistance programs, or PAP programs. These provide patients who need it medication free of charge through an internal program through the manufacturer. They're often limited to uninsured patients, although occasionally do include underinsured patients, so always good to look. And they also typically will only allow coverage and medication for FDA-approved ages and diagnoses and may or may not have financial income criteria. They're not always super transparent about what the eligibility criteria are. Sometimes if you call and talk to someone at the program, you can get a little more information, but it does make it sometimes hard to set realistic expectations for families and patients about whether they will or won't qualify. And certain programs have been revising their criteria in recent years to address the impact of some of those adjustment programs, mostly the AFPs, where they're sort of carving things out and trying to present the patient as uninsured for that particular medication. And then last, third-party assistance programs, so not manufacturer-based, and provide additional financial assistance to help with remaining copays after we've used manufacturer assistance, and for medications like generic medications that just don't have assistance programs. And these do also typically have an income eligibility criteria. So we'll dive into a few specifics. I'm not going to read the chart to you, but feel free to take pictures if some of these are things that maybe you're not as familiar with. Happy to talk specifics after. But we are fortunate in the world of CF that there are lots of assistance options, but understanding what's available and understanding how to use them becomes super important. So for our CFTR modulators, the Vertex GPS program, beginning in 2023, now provides $20,000 annually of assistance. It is unique in that it's a tiered, or there's sort of 2 different options for how medication assistance is available. So for patients who have one of those copay adjustment programs I mentioned, they get $3,500 per 28-day fill of full dosing. That's important. For folks who have a traditional plan, they get $89.50 per fill, up to that $20,000 per year. For Toby, both the Podhaler and the neb solution actually can be covered through PodCare. On the website, it kind of looks like it's only the Podhaler, but the neb solution does actually fall into this too. It offers up to $14,000 per year, and then there's also a copay card for the generic of what we used to know as Bethkis, but tobramycin 300 milligrams per 4 ml neb solution. And then Catabus, one of the other branded tobramycin products, also provides up to $14.40 per prescription with no yearly maximum. Pulmozyme and Bronchitol also have copay cards that offer up to about $10,000 per year. And then the Casein Access program offers up to $8,000 per year, but caps at 7 fills per year, so they're assuming that you're doing an alternating, like every other month sort of thing. This program can also be useful when you need support for replacement Altera units, so another good reason to enroll folks. Enzymes, at this point, all of the 4 major enzymes have their own assistance programs, and they're fairly similar in their setup with a few nuances. They all provide copay assistance, with Zenpep and Creon matching each other at $8,000 per year. Zenpep and Creon they really all offer free monthly supplies of a CF vitamin and then 1 nutritional supplement. The one nuance with Zenpep Live to Thrive is that patients can also get either a vitamin D or a probiotic in addition to those 2 things. The challenging thing about some of these programs is that it's an online portal, so it's something that usually as providers we don't have access to. We've asked, and if others want to ask, maybe they'll eventually give in. But so it does really rely on the patients to know what they need and to be the one ordering it on a regular basis. And then the way that they track patients' eligibility for these is by the copay card being processed at the pharmacy. So you have to fill Zenpep Creon at least twice a year to be eligible. And so what I know at our center we find happens is that in January the copay card gets run and maybe they did have a cost, so we're good. And we're set for 6 months. And around June, July, we start having families say, the portal says I'm not active anymore. So there is a process where patients can upload a receipt from their most recent enzyme fill, and it will make them eligible for the rest of the year. But again, it's one more thing for folks to do. You have to know that that's what you're supposed to do, and so it can present an additional barrier. The Live to Thrive program also has a point system. I know not every state can use this, but for those that can, if patients want to track all of their refills, they can accrue points to use for additional resources, either fun things or additional supplies like nebulizer cups. All right, third-party assistance. So once we sort of look at what's available from a manufacturer standpoint, we can move on to third-party assistance programs. I think we all know and love the Healthwell Foundation and are so appreciative of them. So there are really 3 funds under this now. And then there are others. So there's the Patient Advocate Foundation, the Assistance Fund. We'll talk about a few, but there are definitely also more local and regional resources that might be individual to your center. So Healthwell Foundation first. So the treatments grant offers $15,000 per year, and really originally, was intended to provide coverage for co-payments for most CF treatments, so our CFTR modulators, our enzymes, inhaled therapies. There is an exhaustive list. If you go onto the website and go into the individual treatment fund, it is updated pretty regularly. And if there's something that you think should be covered that isn't, it never hurts to ask. So one of the important things about the Healthwell grants is that you do have to enroll patients in manufacturer-provided copay programs first. So these are intended to be tertiary. So insurance primary, manufacturer secondary, Healthwell third. You can now request once a year for patients to be transitioned to premium assistance. So I think this is a really thoughtful change that they made in the last couple of years, recognizing that most of our patients, if they have a traditional plan at least, are meeting their deductible and out-of-pocket maximum early in the year and maybe not using the rest of that $15,000 that's been allocated to them. So once a year, patients or the care team can help with this, can ask them to be transitioned to premium assistance, and then families or patients can get reimbursement for their premium that they're paying for the plan. I know at our center, we have definitely utilized this more in the last year or so, and particularly for folks who have opted to get a different separate insurance plan for the person with CF because of the differences in medication coverage. This can be really helpful to offset some of that additional cost. It is available for patients with any type of insurance, and that's inclusive of Medicaid, Medicare, TRICARE. You just have to have some insurance coverage. The vitamins and supplements grant, the amount has changed a few times over the years, but $1,000 per year for a wide variety of CF multivitamins, individual vitamins, different infant formulas, enteral supplements. Again, there's a very long list on the website. Not all of these, though, can be electronically billed, and it delineates that, I think, with an asterisk on the website. So some of them do require the patient to pay out of pocket and then get reimbursed. So that's just an important thing to note, depending on whether a patient or a family can afford to do that. And then the travel grant fund is new. It offers $500 per year and helps with lodging and transportation costs. I have not personally had experience with using it with our patients, but if anyone has, would love to know how that has or hasn't worked. And then others. So the Patient Advocate Foundation offers close to $10,000 per year. Similar to the Healthwell Treatments Fund, it covers copays, office visit copays, insurance premiums. And one important sort of nuance of it is that it does cover CF-related diabetic supplies. I'm not sure it's the most straightforward to get the reimbursement for, but they do. Another note, though, is that it automatically closes if it's not used within 60 days. So again, just thinking about timing and if folks are meeting their deductible and out-of-pocket maximum, making sure that patients know we still need to be using it somehow or it might not be available later in the year. The assistance fund, I left the amount available blank because I've never been able to get a straight answer. But it does cover copays and office visit copays, but these two are often waitlisted. So keeping an eye on them and maybe, being strategic and prioritizing if you have patients who really need to use these because they just kind of come open and close very quickly. And then another one that we've used, I'm a PEDS center, is the United Healthcare Children's Foundation. It offers $5,000 per application, up to a $10,000 lifetime maximum. It's only for people 16 and younger, so definitely a PEDS thing, but something to consider. It, at least when I made my slides, was currently open. Don't hold me to that. But it does also intermittently close. And so you're probably also now thinking, that's great. So insurance is not great. And there's all these resources, but how do you navigate them? Because it's an overwhelming amount of information. It changes all the time. But knowing how to use these things strategically can really help offset a lot of costs for families. So unfortunately, I think the first step is understanding a patient's individual insurance plan, understanding how it works, how it's set up, how it applies copay assistance to their deductible or not, and getting into the weeds of specific medications. I'm going to go ahead and do my first shout out for Compass. They can be super, super helpful with this. And we ask them questions all the time about insurance plans that are common for our center, but we also refer individual patients to them, and they will walk through with families at a very patient-friendly level what the differences are and can help with navigating, selecting an insurance plan, all of that. So that's my first maybe of many plugs for Compass. After that, looking into financial assistance through the drug manufacturer first. Most of the third-party assistance funds, when you apply, you are attesting that you have exhausted those options, so making sure that we are doing things in the right order, and then looking after manufacturer-based assistance programs at your third-party funds like Healthwell. I think, again, something our center has learned over the last year or two is that even for patients who have met their deductible and out-of-pocket max, considering how to use that premium assistance for additional financial assistance through the year has been really impactful for patients. And so just being strategic about when did you apply for Healthwell, when will they need copay help, and then when can you flip it to premium assistance for the rest of that 1-year lifetime of the grant. And again, ask for help. Again, Compass, they are super helpful at both looking at trends for your center. They can tell you trends for your state and more nationally, what they're working on, what's going on, but they can help at an individual patient level. And I know every single time that I refer a patient to them, I usually get an email that day or the day after saying, thank you so much for connecting me with whoever they talked to. It was really helpful. I feel like I understand better. So definitely we as care teams need to understand this, but also knowing that we have a great resource to help us is really helpful. And with that, I'll take questions. Right? Or are we doing it at the end?
Yeah, I think we're
Okay.
doing it at the end.
Okay.
Cameron, this was really helpful. I want to direct everybody, in case you didn't see, Hannah Fan is another pharmacist who presented earlier. If you look her up by name, last name Phan as one of the speakers, she included in her handouts one on how to word your letters of medical necessity for mostly medications such as like the tobramycin, and then there's another handout also about for respiratory equipment. So those are some great tools to have in your pocket. Obviously, we share across all disciplines, so I just found those useful too. So I wanted to give her a shout out for those. So next up, I'm very fortunate to introduce Carol Chase. Carol is a practicing clinical social worker at Children's Hospital in Washington, D.C. Help you get here.
Thank you, I appreciate that.
She serves children, adults, and caregivers who are living with cystic fibrosis. She's a certified partnership enhancement program trainer since 2019, also known as PEP. If any of your centers have not yet participated in PEP training, I highly recommend it. There's a virtual option as well as an in-person option for team members, and it's really worthwhile to enhance communication not only across your team but also in your interactions with patients and families. A little plug. So she's working with PEP colleagues to share a relationship-centered communication approach to exactly what I just said. Carol has a special interest in advocating for non-English speaking individuals trying to access CF care, and we're so grateful that you're here with us.
Thanks, Lena. And as I put on my disclosure slide, I'm a PEP trainer. Sorry, didn't add that. So my topic this morning is the mental cost of CF. Cameron so nicely spoke to us about the financial challenges that a lot of our patients and families endure to try and get treatment of the disease. And what would really help me, just so I know who my audience is here and your experience with all this, I know we have a lot of new people in the CF community this year. How many of you, raise your hand, have been in the community 10 years or more? And people who are new to the community? Good, okay, thank you for that. So your patient comes forward and now they're ready for therapy. Now what happens? What's the next step? Where do I start? Don't you know somebody that I could see? And I want to work with somebody who knows CF. To me, the patient wants someone familiar, someone who is familiar not only with their burden, but all the stuff that goes in it so they don't have to start at the beginning. And basically, that means you, right? They don't want to go elsewhere. So they don't even know where to start or who to start with. There's so many choices, right? We have psychiatrists who basically are responsible for diagnoses and medication management. We have psychologists who are responsible for educational testing and behavior changes, cognitive behavioral therapy. Social workers like myself who are trained to do counseling and therapy, along with licensed marriage family therapists, and maybe even a pastoral care counselor at the church. But each of these come with financial burdens, and each of them come with a real challenge of access. If you happen to be in the Washington, D.C. area where I practice, these can be pretty costly. A psychiatrist is upwards of $175 per session, and that's with insurance. Without insurance, it can be as much as $400 a session. A psychologist is similar, somewhere between $100 and $350, and even the pastoral counselors are charging $215. So it can be pretty costly without insurance, and if your insurance wants you to pay a portion of that, right, it can be even more costly. So Medicaid does cover some mental health services. Medicare Part B will cover outpatient mental health services. Most private insurances are 80-20, so your insurance will pay 80. The patient is responsible for 20% of that. The out-of-pocket, it's all on us. And then there's, of course, the sliding scale fees, the pro bonos, where you can sometimes get free clinics. And then there's the struggle of whether you're going to go in person or whether that individual is going to provide you a telehealth appointment. But really, it's more than that, right? When you try and find yourself a mental health provider, there are real challenges of where you need to go, who you need to see, how often you need to see them, time off of work. If you have children, that means you have childcare cost to provide a care provider while you're going to get care. So there's a lot of associated costs. And many of our patients will even say they're not interested in adding yet another care provider to their team, right? They've already got pulmonary and endo and GI and ENT, maybe even a transplant team, right? And now you're asking me to go see a mental health provider? Like, they've had it. Hold up. So there are a number of ways that we can make this happen, and we can talk about that a little bit more, but I want you to really think about, for a minute, those individuals, even geographically. So in the Washington, D.C. area, we have a number of providers, and a lot of our providers, because of where we reside, they have licensure in Maryland and they have licensure in DC, which are two of our surrounding states. But if you're living somewhere much more rural, those providers aren't available to you, and you don't have choices. And maybe the telehealth isn't even available to you because that practitioner doesn't provide telehealth resources, or they're not licensed in the state that you're looking for. So there's a lot of challenges going into trying to find a provider. And then our patients will share with you that their provider doesn't know about CF. So they're going into a session having to pay $250 to educate that individual about daily CF care and why it's such a burden to them. That's not okay. They may have knowledge of chronic health issues, maybe not CF related, so that they have some familiarity, but not CF in particular. And certainly with the modulator therapies that are coming out, the patients who are feeling survivor guilt, that their friends are dying and they're supposed to be living, and they haven't made plans for a lifetime because they didn't think they were going to have one, becomes a real emotional burden. And maybe it's a good burden to have, but it's a burdensome, keep you up at night, insomnia kind of feeling when you don't know what you're supposed to do with yourself. And then there's medications. There are interactions between the list of medications that some of our patients take and the mental health meds that are offered by providers. So really, our patients aren't wrong. We should be engaging mental health providers who are familiar with that med list, who can make choices that will work with us. And then there's that goodness of fit, right? We all feel it. When you go get your hair cut, and it's a bad haircut, that is not a goodness of fit. The same is true with your medical providers, right? The dentist, your GYN, your primary care. You don't want to go to somebody that you don't feel is hearing you, listening to you, doesn't have knowledge of what you live on a daily basis. So that goodness of fit is super important. So then we get to the medical trauma. And I think that many mental health providers would be able to speak to some of this with our patients. But I want to remind you that this is both a psychological and a physiologic response. So some of your patients may be coming forward and talking about somatic symptoms of their health experience, their mental health experiences, which really are related to mental health choices. So the stomach aches, the difficulty breathing, the night sweats, the GI symptoms, right? It really takes a solid provider to be able to tease out what of this may be related to meds, enzymes, Miralax, even some of the meds that you're taking, and how much is really related to the psychological and physiologic issues that we're challenging our patients with. So medical trauma really sometimes can be post-traumatic stress disorder for many of our patients. It's a repetitive experience. It's emotionally and physically distressing to them. Oftentimes they have difficulty talking about it to us, to our providers, because they feel shame. That so many times I've had my port accessed. I've had so many intravenous therapy lines. I've had so many blood draws. You would think that this is easy for me. It's not easy, and it doesn't get better without treatment. And it affects the extended family in the same way that it shares with the patients. So families may feel responsible, that they're the ones who are bringing their patient to care, to get this care, and that care is traumatizing that person. They may feel guilty about standing by and watching their family member having this care. And they oftentimes feel shame also, that they can't help. They can't fix it. You know, Cameron did such a nice job about the insurance coverage and reaching out for other resources. This is one area of mental health that really has to be addressed by a professional. Some of our patients talk about feeling crazy, being disassociated, sitting up in the corner of the room and watching all these things happening to me, and realizing that it's only getting worse, it's not getting better. And it's really becoming intrusive for some of them in their daily lives, such as work, interactions with others, etc. And then we have our highly effective modulator therapies, which for some people have been wonderful, right? So for those of you who are newer to our community, this is a medication our patients take twice a day. There are a number of different ones of them. They require at least one delta F508 mutation for use, and, as Cameron would tell you, an insurance policy that covers it. And you'd be surprised, there are some who don't. So there are, of course, a number of people who are ineligible to take it. There are some exclusionary criteria that even if you are living with that mutation, that you're still not able to take it. And your healthcare teams are much more familiar with these things, but I wanted to give it a shout out because it's a real thing for a lot of our patients that everyone else is available to get this medication and I can't. So really investigating the contraindications of some of these modulators for our patients have become super important. And this wasn't something that initially was identified when we were doing safety testing for these. And there's a number of articles, even by our own CF community, that you can read on that will share these with you. But basically, some of our patients, when they take these modulators, they experience worsening depression. Their anxiety becomes even more intense. Some have identified feeling suicidal. Some have actually had suicide attempts, which require inpatient hospitalizations. Some people experience sleep issues, brain fog, anger, anxiety, the list goes on. Not only medical issues, but also mental health issues is what I'm really trying to get at. But as Cameron said to you, I don't want you to leave here without hope. There is hope down the road. So our foundation, the Cystic Fibrosis Foundation, has a number of very useful resources for patients who are looking for social supports, not feeling isolated. There's CF Peer Connect. Community Voice has a number of ways to connect patient to patient. Even some of our caregivers can be connected with another caregiver. There's a racial justice working group, which is for persons who are Black, Indigenous, and people of color so that they recognize that this is not just a one-size-fits-all Caucasian illness. It affects everyone. And our friends at Compass, God bless you all. I send my patients regularly to Compass, particularly when they're transitioning into adulthood and they're getting new insurance from their patients' coverage or from their parents' coverage, and they need to learn about their own insurance. Compass will do a free insurance analysis, and it's really very useful. Our DC Metro chapter of CFF and myself run an online monthly community cares group, both in English and in Spanish. All are welcome from across the country. We've actually had folks from across the world come and join us, which has been really kind of fun. If you're unfamiliar, the foundation has a number of online programs throughout the year where young adults and persons living with CF help plan these programs. BreatheCon, FamilyCon, ResearchCon. There's a Grampians group that are grandparents from across the United States who come together to learn how they can support their family members. There's Living Older for adults who are living with CF. Many of you are familiar with the CF Library, which has all kinds of resources for providers to help with their patients. The Partnership Enhancement Program, which Lena so nicely recognized, and also the mental health group has done a lot of work to put together resources for care teams to try and help their patients and direct those patients to care. There's also the CF Rise program, so our patients can learn more about their own health and share that with their providers. The Lifestyle Foundation is a exercise program, as is the Breathe Strong program. There's also meditation apps that you can direct your patients to, and they can use these things in adjunct to working with a mental health provider, and also really to get started and to help understand what's happening to them. Many of our patients also use art, such as painting, play, coloring, to help reduce the feelings of anxiety and worry. All of us should be asking our patients to incorporate some kind of exercise. It's good for us, it's good for them. There's journaling, writing, even recording on your phone how it is you feel and what's happening with you, and sharing that with your mental health provider so that you really can get to the meat of what's happening with you at a particular time. For those people who are experiencing anxiety, if they can tolerate body massage, it's really a very wonderful way to help the body recognize relaxed and tense states. Not everyone can experience that body touch as a comfortable thing, so you really sort of have to fend that out with your patients. And then, of course, music. There's all kinds of music out there that can help our patients. And then our friends out on the West Coast, Cystic Fibrosis Research International, has an adult peer group in Spanish, also in English. They have the African American Community Video Project. Attain Health has a number of groups, and also the National Organization for African Americans can really help our patients feel included and speak to others who are experiencing similar feelings. Our friends at Kaiser Permanente were thoughtful enough to share this with me in sort of another way to just look at the multifaceted way we can help our patients address the emotional well-being that all of us are seeking on a daily basis. And they really can sort of choose from this. They don't need to do all of it, but it's a nice way to sort of group these things to help them get started thinking about how it is that they would like to address their emotional and mental health status. And then last, I will put a plug out there for our Mental Health Advisory Committee. Not only have they put together these really nice tips for our care teams to use with our patients and families, they have also put together the mental health peer consultation groups. I myself run one, Mondays at noontime. And it's for providers so that we can talk about how it is that we can support our patients, support our care teams in supporting our patients. And anyone can join these groups. There are multiple groups across the country at different times, so we've really tried to make them available to all of our care providers. And then I think Chandler was sharing with me this morning, the PEP team actually has just put out another resource for care teams about how to help their patients and families access mental health care, which is hot off the presses. So thank you for listening. Be happy to take questions that arise.
Thanks, Carol.
You bet.
Our next speaker is Rebecca McWilliams. She's a senior program specialist with the Cystic Fibrosis Foundation. Prior to her current role, she served as a Compass manager for 6 years, seeing issues firsthand as a case manager. She's particularly interested in how social factors, healthcare costs, and insurance coverage challenges the impacts the CF community. She maintains a Mastered Certified Health Education Specialist certification from the National Commission for Health Education Counseling and a Community Resource Specialist certification from Inform USA.
Thank you. I have no relationships to disclose. So today I'm going to share with you a little bit about who Compass is and what resources we can provide. So we are a team, we're part of the Cystic Fibrosis Foundation, and we are a trained team of patient advocates located all over the United States, including 5 Spanish-speaking case managers, which is really exciting for our Spanish-speaking population. Most of whom have personal connections to CF prior to coming to Compass, and I can assure you we all have personal connections now after having the privilege of working with this community. So we are really here to help you and your families and patients navigate anything from insurance, financial issues, connect to legal resources, and really anything that comes up, because as you know, a lot can come up related to CF directly and indirectly. For our eligibility, we really the only eligibility is that you have some sort of connection to CF, whether it's people with CF, their families, providers, and also people with CRMS. But we don't have any insurance criteria, income criteria, care center criteria, and our services are always free and confidential. And this is just a brief snapshot, which we'll talk a little bit more in detail about, of some of the things that we can help with. So we can help with people choosing insurance options, whether they have a couple employer plans to choose from or they're not sure what their options are. We can help them identify what they're eligible for, what would make sense, and provide them some detailed information about plans. Help them verify their insurance coverage and benefits, help them troubleshoot any insurance coverage issues, connect with any resources or support programs, connect to legal resources for questions about laws that protect the rights of people with CF. And we have a lot of educational tools and resources for navigating life with CF. So just education to learn more about certain things. Of course, we always have the one-on-one support, but if people are just looking to learn a little bit more and navigating themselves, we have a lot of resources that are available at the booth and inside the NACFC app too. So as far as our scope, so there's a couple of things that we are not experts in. So we don't provide any medical advice. We really leave the treatment plans to the provider, the care teams, and their patients. So we're not medically trained. We don't provide any medical advice. We also don't offer any direct financial assistance, so we connect to direct financial assistance, but Compass itself does not provide direct assistance. And we do not in-house provide any mental health counseling. We're not mental health experts. We connect to resources for those, but don't provide any mental health counseling or legal advice. So same, where our expertise is not in the legal space. So we have a lot of referrals and good relationships with people who are experts in that area. And finally, we don't recommend any specific for-profit businesses or services. So for our insurance space, so we can help them identify, usually, we don't ever recommend just like one plan, like you should go with this plan for this reason. Usually, because that would be just one person's opinion. So we usually provide them a comparison of, let's say, like 3 plans that we've identified that cover most, if not all, of their needs, at least on paper, and kind of talk to them about these things are covered, but more importantly, too, even though it's covered, what can you expect as far as cost for these things, and when can you expect cost to change with your deductible kicking in and things like that. So big, really important conversations, educating them about what these plans look like, what are you comfortable spending, what can you spend, and what makes sense for you, your situation, your family. This year, if they have surgeries or procedures or things coming up, we can factor all of that into the decision and identifying their priorities for the year coming up. And in the insurance coverage space, this is certainly not all-inclusive. These are just some of the most common things that we encounter on a daily basis. So anything as far as unexpected medical bills or bills and collections, coordination of benefits where they have more than one type of insurance, and figuring out who's primary, who's secondary, how those should be getting billed. Switching pharmacies, whether switched insurance, so the pharmacy they were using before is not going to work as well anymore, if the pharmacy is now out of network, anything related to pharmacy issues, and medications or treatments no longer being covered, or a denial for something. And network exceptions, so if a provider or facility is out of network, we can help in that space. And then finally, benefit verification, which is more of a proactive. So if they have something, a procedure coming up or something coming up that they want to see they've been prescribed something, they want to know approximately the cost and the benefits, we can help them take a look and give them an approximate of what they can expect for that upcoming service or treatment. And resource navigation, a huge, huge part of what we do. So this slide is specifically for some of the more directly related to CF costs. So medications, their vitamins and supplements, their durable medical equipment like their nebulizers and vests, co-pays for doctor's visits, insurance premiums. So we help them look at what they're eligible for, like are there things in their county or state that they're eligible for? Is there some sort of state program they could be using as secondary? Manufacturer copay assistance, nonprofit copay assistance, grants, things like that. And a big part of this too is when we talk to them and they have a specific need, we try to assess other resources they're already using too, and make sure they know of everything that they could be taking advantage of. How can we maximize those benefits for them, and recommending any additional resources that they don't already know about and are not already using to help them to make the most of what they're eligible for. And then another part of our resource navigation is really anything else that could fall perhaps outside of the actual treatments of CF, but living expenses, social determinants of health, and this is not all inclusive. These are some of the most common, but we really keep this kind of open-ended because every day we're finding resources for things that we didn't know existed or didn't think existed and do. So I would really encourage you to, if something comes up or you think of something or have a patient that has a specific need, to refer them or to ask us, because we might know of something or can research and maybe find something. And even if we can't find something for that specific need, usually in the conversation and working with that family or with you all, there's something else that we can identify that would still help them free up some funds, even if it's not the exact thing that they needed. So we're very flexible in that way. There's usually some type of resource out there. And for legal, so we have the CF Legal Information Hotline for anything Social Security related, applying, questions about that, going back to work, anything related to employment or school rights, insurance law. And then for anything else legal that would fall out of those kind of three categories, we refer to other local, either county or state, bar associations or other pro bono legal aid in their area that's appropriate. And we also have a Compass resource database, which is a tool that anyone can use. It doesn't require a login. So this is for anyone in the CF community, care teams, families, anyone can use this. We have some, as you can see on the bottom, some guided searches for sort of, we've lumped some resources into categories to help find things easier. But this is not an all-inclusive list of everything we know of. We're adding every day to this list as we vet resources and are monitoring their open, closed, is their criteria changing, their application process. So this is an additional resource, but if there's if you can't find something on here, we might still know of something. It just hasn't been put in here. It hasn't been uploaded yet. So. And that QR code will take you to the resource database. It's mobile friendly and device friendly. And how does this work? So how can we work together with care centers and families to have a positive outcome, to get person with CF what they need? So Compass can do a lot of that research and take a lot of that time burden away from families, one, either having to be like on hold with the insurance forever or fighting with their insurance about something. We can do a lot of that, like researching resources or contact the insurance to figure out what the problem is, what the potential solutions are, and then obviously keeping in contact with families and care centers, updating them on the status. If it's something that would be perhaps needed by the care center, like something medical related, like a prescription or prior authorization, appeal, like something that would be submitted by the doctor's office, we can bring them in, communicate them. So in this process, hopefully we can all work together as a team to get that patient successfully what they need. And to kind of further streamline that, we've made some changes this year to our consent process. So historically, we needed a physical consent, either a paper copy that was mailed or faxed in, or we have an online form where they create an account, submit consent, and it comes back to us. But to break down some of those burdens of putting something additional on the family to fill out and get back to us before we can start working on their case, we've switched to verbal consent, so we can now collect that on that first intake call, and nothing else is required on their end for that. So then we can go ahead and start working on the issue immediately as soon as we have that call and hear what the problem is. And hopefully this will help us better collaborate with care teams too, because if we know that care teams are aware of the problem or they referred the person to us, we can get that verbal authorization right there to communicate updates, get their permission to let their care center know what's going on, keep them in the loop, and give them updates. And I want to share just a couple of case examples too. So like, what does this really look like in our day-to-day practice? How can we actually work with care teams and people with CF, and what are some of these examples of cases? So some details have been changed here just for privacy, but these are very much indicative of cases we see every day. So this first example is about the Altera not being covered by Medicare. And we know, and the pharmacy knew that HealthWell would cover it, and they were eligible for HealthWell, but they were getting a denial. It wasn't being covered by HealthWell. So the case manager was able to call HealthWell, figure out what was going on. It turned out they needed to see a denial before they would cover. So the case manager was able to coordinate with the pharmacy there, get that denial from Medicare, and then HealthWell was able to cover the nebulizer. So person with CF did not end up with that out-of-pocket cost for the nebulizer. This is a little bit more of a in-depth coverage and reimbursement, sort of benefit verification, I guess. So usually, a lot of the vest prescriptions that we see come through at the insurance as a rental, and usually longer than their plan year. So this rental contract was going to be for 18 months, which would run into the next year. And this family had a really high deductible, a really high family out-of-pocket maximum. So it wasn't financially making sense for them to have this payment plan for the vest, and then when the year changed, the deductible reset, they were going to have a much higher copay, or much higher copay with that deductible resetting. So they were going to end up paying more by renting than purchasing. So they wanted to pursue, if purchase was an option, like a one-time payment, since they had already met their deductible for the year. That was making more sense financially for that family. So the DME provider that it was initially through, and this was a vest that goes through DME instead of the vest manufacturer, they were more familiar with rentals. So initially they were saying that they don't do purchase, they only do rentals. Then the case manager looked for a couple other DME companies that were in network with the patient's plan, was hearing the same thing. We don't do rentals, or we don't do purchase, we only do rentals. So ultimately they ended up back at the initial DME provider. We're able to kind of escalate to a manager to see if they could do a purchase, or if it was truly that this company would only do rentals. And after escalating, they found out purchase was possible, so great, we're going to stay with this DME provider. Then comes the insurance, and the prior authorization was for a rental, so case manager was able to work with Care Center to get a new updated prior authorization for purchase, and then needed to do a little bit more work then with the insurance company, because the insurance company also, their default is rental, so they were like, no, we don't do purchase, we don't have a code for that. So case manager then kind of had to start the process all over again, get the third-party administrator, the insurance company on the phone, get them to agree, this is in your contract, you do purchase, get them to release a billing code, and ultimately, person with CF was approved for the vest purchase, so a one-time payment instead of a monthly rental. But here is a good example of case managers at Compass can do a lot of that on the phone with insurance company and save you all that time and frustration, and save family that time and frustration on the phone, being told no over and over and over again. And so this example was for the Monarch, which was covered, but with a very high copay. So first, the case manager looked into making sure it was covered correctly, researched financial assistance, helped the typical DME financial assistance that we know of. Some of them were closed, so they were able to ask a resource if this was something they would consider, which they said yes, they would consider. So we were able to refer them to that program. And then also in working with this person with CF, the case manager realized that they had COBRA, so they were paying a really high premium. So the case manager was also able to refer them to a resource to help with that COBRA premium to free up some funds there for a program they were eligible for and able to take advantage of. And lastly, this example is about diabetic supplies, where a person with CF was having copays for their sensors, even though they had secondary coverage through an adult CF program in their state. So they were still having copays. So first, the case manager was able to talk to the pharmacy, figure out what was going on, why the secondary payer wasn't being billed. And it turns out that in their verification system, the secondary insurance was showing up as inactive. So next step, the case manager calls that adult CF program with person with CF to make sure their coverage is active, that we have the right member ID and information, confirming it is active. Then case manager goes back to pharmacy and is able to escalate to billing to be able to manually add that secondary payer, because their automatic verification system was kicking back that secondary payer. So ultimately, this person was able to get these sensors with no copay and use their primary and secondary insurance correctly. And so how to contact Compass, other than just referring people to our phone or email or online form. The care teams can reach out directly to us to share issues, to get resources, and then we also have a warm transfer option. So if you have people that you want to make sure get in touch with us but aren't sure that they'll reach out on their own, or just want to make sure that you know that they got to us and we have that contact point and we can take it from there. We do have the warm transfer option, so conferencing with your patient when you have them in clinic, or just if they call, conferencing them, and then you can stay on the line or you can drop off the line when you connect them, totally up to you, or emailing Compass. If they're okay with you copying them on your email to Compass and just introducing them, and then we can take it from there with them. And I just wanted to plug here, so a lot of the issues, we really rely on care teams to tell us about things. So even if it's not a trend, even if it's just one patient you have that has an issue, a lot of our policy and advocacy work is informed by hearing about things that your patients are going through. So you sharing with us or referring your patients to us really helps us and our policy team inform their work and help them identify, is this an area where we can reach out and advocate with this company or this state and help improve some of these access issues and barriers to care. And then this is our contact information. So we have a phone line open Monday through Thursday, 9 a.m. to 7 p.m., Fridays, 9 a.m. to 5 p.m. We have an email, and then we do also have an online form where people can submit requests, and the online form is only available to people with CF or caregivers, parents, or legal guardians. And finally, some of our future plans. So we're always looking to improve and change. So expanding our follow-up with care teams, so really making sure we have a concrete plan in place for, if you refer someone to us, are you getting that closed loop? Are you hearing the outcome, if we were able to help them, what the outcome was? Really making sure that when you refer people, you're knowing that the person was taken care of, or you're aware of the update. And then exploring new communication tools for, other than our phone and email and online form, exploring things like texting, for accessibility and new ways for our families to reach us and or provide them updates.
Thanks, Rebecca. Thank you so much. Remind me, I have to tell you about a policy update. As we load in our video from our patient voice, I just want to introduce the amazing Braga. She really, really wanted to be here today, but as we all know, it's really difficult for patients with CF to actually participate in NACFC, even though it's all about them. And we did look into a virtual option, but it wasn't available. So Braga Vanti Chimere Dunwoody-Charles, affectionately known as Braga or Baby, was born and raised in Perry, Florida. She was diagnosed with cystic fibrosis at just 18 months old, and defying the odds and surpassing expectations for individuals with CF. She has led a vibrant life while navigating the challenges of this condition. perfect. Or we could go a couple seconds so you can see her beautiful face.
So make sure there's audio.
Oh, yeah, you do that.
Yeah. Okay. So do we
Yeah,
want
let's play just a couple seconds until she's in the chair. Perfect. Thank you so much.
You're welcome.
Here she is. Throughout her childhood, Braga received care at the University of Florida Shands Hospital Pediatric Clinic in Gainesville, Florida. Is anybody from there? Okay. She very passionately wanted to say that she was well cared for, so wanted to give a shout out to there, but she's currently under the care of Baylor in Houston, Texas. Braga's a nurse. I think this resonated with me as a nurse as well because her path has been just so strong, and to have faced this disease, gone to nursing school, and then done a career in nursing, and then faced those challenges, as you'll hear, it just resonated with me. So she got her nursing degree from Florida A&M in April of 2006. She began her career in a step-down ICU and has since built extensive experience in a cardiac ICU, step-down ICU, procedure care units, emergency room, travel nursing, and more recently, ambulatory care with a focus on cards. So again, as a nurse, she was in these really intense environments that can be physically and mentally exhausting. I'm so proud of her. Her passion for teaching and mentoring led her to achieve a master's degree in nursing from Prairie View College of Nursing in Houston, Texas in May of 2018. Her notable career achievements include overcoming the challenges of cystic fibrosis to advance to the roles of nurse supervisor and ultimately nurse manager of cardiology during her decade at Kelsey-Seybold Clinic. Braga's dedication to excellence is also reflected in her memberships in esteemed organizations such as Delta Sigma Theta Sorority, the National Women of Achievement Incorporated, Top Ladies of Distinction Incorporated. But due to her ongoing battle with CF, Braga, at the age of 42, has physically been unable to maintain her 18-year nursing career and social activities. Despite these setbacks, she remains optimistic about finding a cure and is committed to managing her health through rest, continuous treatments, and regular medical appointments. So I'm so grateful that she was able to participate virtually, and you'll hear from her yourself.
For me, the cost of CF is not just physical. It is also emotional, mental, and relational, and it has a huge financial impact. Hi, my name is Bragavati Dunwoody-Charles. This is my journey. This is my story. I've always been curious as to how I was diagnosed with cystic fibrosis. So the story that has been shared with me was that it was in 1983 during a routine visit at the local health department that at the time my late great-grandmother and my mother expressed concerns to the provider about my repeated bouts of respiratory illnesses, my foul-smelling stools, and the failure to thrive. The provider picked me up, kissed my forehead, and to him, it tasted like he licked the top of a salt shaker. And we all know back then, that was a significant indication of cystic fibrosis. That provider referred my family and I to Tallahassee, Florida, Children's Medical Services, which was 50 plus miles northwest of my hometown of Perry, Florida. And from that appointment in Tallahassee, Florida, I was tested numerous times for cystic fibrosis, each time coming back positive. It was almost unheard of in 1983 for an African American, particularly African American female, to have cystic fibrosis. Excuse me. So my care was then transferred to Gainesville, Florida, which is now an hour and a half southeast of my hometown. My care was established at the University of Florida Shands Hospital Pediatric Clinic. I recall during that time of the 20 plus years of receiving care at Shands, of the numerous drives to and from appointments, the long day events, of appointments, waking up at 6 a.m. and for a 9 a.m. appointment and spending most of the day there, and then that drive back home. But what is most profound in my memory is the impact that that clinic made on shaping who I am today, as well as influencing the professional I wanted to become. It was because of my experience with the physicians, the nurses, the case managers, and the social workers that I wanted to become a nurse. It is because of my interactions with the providers and the tailored care that helped shape my career. I am an author on the CF website of how cystic fibrosis shaped my life. And I can say now that it was because of that Shands clinic that I was able to become a nurse, as well as have a successful career, all while managing the challenges of having cystic fibrosis. I remember the numerous conversations at that time in the 90s of may not see my 16th birthday, may not see my 18th birthday, and I can stand before you all today to say that I will soon be celebrating my 43rd birthday in November. It is because of my experience with that clinic that I have so many aspirations in life, and that I was able to accomplish many of them with their support, with my family's support, with my friends' support. So my career took a backseat to CF. With any new nursing job that I started, upon eligibility, it was important for me to select all employer-offered benefits, such as selecting the highest tier for medical plans, both short and long-term disability plans, and other supplemental plans to offset costs in the event I could not work. However, during my recent employment, around the beginning of 2021 to 2022, through 2022, there was a shift in healthcare coverage with my current medical plan, for which my current CF provider, my PCP, as well as other specialists such as my GI doctor, my endocrinologist, my ENT, nose and throat physician, all were now considered out of network. And because of that, it produced unexpectedly higher out-of-pocket medical costs for me. Some of which, because I was still working, I was able to cover, but some I could not. And as a result, I had medical debt. Still to this day, some of that medical debt, I have been unable to maintain payments to where it has been sold to collection agencies. That's another story for another time. About 2 years ago, my physician and I requested ADA accommodations through my current employer for remote work, which they approved for 2 years. And that was because, again, having CF, it comes with some challenges, and with those challenges, oftentimes you need accommodations. But I was thankful that I had developed and built a rapport with my employer at that time for 8 years, that they saw my work ethic, but also wanted to support me in managing my chronic illness and my health to where they agreed to accommodate me. But that was for 2 years. So after those 2 years, they could no longer accommodate me. And unfortunately, I didn't get any better. I really hoped that I had gotten better, but I didn't. And so then I was faced with one thing that I still to this day can't really admit or accept deep down inside is disability. So, excuse me, during numerous visits, whether they were well visits or sick visits with my CF team, they would always provide information about Compass. Oh, I don't need it. I don't need it. Oh, I'll take it and it'll go in my office in a drawer or sometimes in the trash. But there came a time where I needed Compass and Compass was there for me. I reached out, I received a call back, and I was connected with the CF Foundation funded attorneys, disability attorneys. And I learned a lot because it allowed me to ask questions realistically about what it would look like if I was unable to work, which I'm not able to work now, but I'm pushing myself, right? But really, what financially did things look like for me? And so I was given some questions and some homework, and that was to go back and research all of these employer-offered benefits that I had selected and paid for many, many years. And of course, that took some weight off, but it did not take all because I still wanted to be that nurse. I still wanted to care for people. I still wanted to educate future nurses. I still wanted to lead great seasoned and new nurses. But unfortunately for me and CF, that was no longer my trajectory or future. So that was a turning point. And not only my health, but my life. Having to sit down with my husband and say, is this something that we could afford? And it's like, we have to afford it in terms of my health because I'm not able to perform the jobs and I don't want to be fired and then lose the benefits, right? But then emotionally and mentally, the cost for me, I'm still paying that cost. It required some adjusting and more medical debt. Because once my employer basically gave me my termination, administrative termination, the clock was ticking for me to then join my husband's healthcare plan through his employer. And understanding that now I have, in the middle of the year, a new deductible. I've met my deductible from my former plan, but now I'm on a new medical plan with a new deductible, higher deductible. Out-of-pocket cost for me in 2023 significantly increased, and it caused us to have more medical debt. And in the process of me trying to manage my emotions and accept defeat, which I'm reminded I'm not defeated, but I feel like I am, now having debt and hoping and praying that I could maintain the life, and not just the life, but the home that my husband and I built off of a 2-income household. And not only that, I still had health issues that we were still faced with, and hospital admissions and surgeries. And so it was this transition. I'm still transitioning emotionally and mentally. And physically, I still have CF. Physically, I'm still struggling. But I desire to encourage others by my triumph, but I also desire to encourage myself knowing that this is my right now. It does not have to be my forever. I am hopeful. I am prayerful that there are going to be modulators that I will be eligible for that will allow me to return back to the workforce. So, of course, with any chronic illness, there comes the duty of managing the medical costs for that. And what did that look like for me with cystic fibrosis? So it did consist of me utilizing copay assistance programs for my Pulmozyme, for my Casein, most recently for my pancreas, as well as my multivitamins. The pancreas program does provide assistance with supplements. However, you snooze, you lose. So oftentimes when I go to the website, their boost is already sold out, but I'm still appreciative for assistance with my pancreas and my multivitamins. Because there was a time where my copay for pancreas was $100 a month. And then it was reduced to $70 a month. And because of the copay assistance program, now it's $0. But that's not all the medications that I have to manage the cost for. I also have CF-related diabetes. And because of that, that's an additional cost that I was not prepared for. So in 2021, when my body needed insulin, paying $100 a month for insulin, not including the needles to go along with the pens, and the additional glucometer supplies. Because prior to starting insulin, the average cost for me in managing my diabetes was $100 a year, maybe. You know, not having to check my blood sugar that often, only doing exacerbations of when I'm not feeling well. Excuse me. But that cost then has now increased. And when I learned about Dexcom, how exciting is that? That you don't have to prick your finger 3 to 5 times a day, depending on how you feel. So my doctor agreed and sent a prescription for Dexcom, $120 a month. Wow. But I didn't want to prick my finger anymore, so that's a sacrifice that I made. And then, was able to reduce that down to $100, but still, that's just in managing the CF-related diabetes. Not to consider or take consideration I have sleep apnea. So I have supplies monthly that I need for my BiPAP machine. And then the distilled water needed to clean my neb cups and to maintain my BiPAP machine. I remember when distilled water was $1.09 a gallon, and now it's $2.49. But again, it's a cost that I have to cover. Like, there's no shortcuts around it, right? And in addition to, I love Pari products, particularly those Pari nib cups. I love them. I take advantage of when I go to see my CF doctor, excuse me, to get the free cups that they give, the respiratory therapist, provides. But again, those Pari nibs, that's another expense. Now, luckily, it's only every 4 to 6 months that I need to replace them or order new ones. But again, every month, the cost in managing cystic fibrosis is a task. It has its own budget for me, not including my supplements, like Ensure. I'm struggling now with my diet and no appetite and weight loss. And, it's vital for me to consume some type of caloric or protein intake. And Ensure is my go-to. But Ensure is expensive to where I have to ration it out now to myself. 2 a day Some days I skip, some days 3 a day, 1 a day, you know? And so we make it, my husband and I make it work, but it's not without its challenges and sacrifices. And with those challenges and sacrifices and just managing cystic fibrosis, and comes the mental component. And for me, most of it is stemmed around my appearance. Because when you see me, I look great, is what I'm being told. But I wish I felt as good as I looked. And I had a conversation with Dr. B about it, you know, and worried about my image and how people see me, you know, and she's like, but you don't feel as good as you look. And that is my reality. And so then I struggle with, when I leave my house and I attempt to go out, do I take the time to share with those who like, oh, you look good, you look great, to say, well, thank you, but I really don't feel as good as I look? Or do I take the compliment and just move on? And so oftentimes it's like having zero energy. I just stay home. And that wears on me emotionally. And I understand more now than ever before that my mental and emotional health is equally important as my physical health, and it requires management. And for me, that management is medications twice a day, as well as weekly therapy sessions, and enduring my exacerbations or crises, bi-weekly, twice a week therapy sessions. So, in conclusion, I thank Lena and Angela, as well as the NACFC, for giving me this opportunity to share part of my story, part of my journey, one of triumph, right? But one that's realistic for an adult living with cystic fibrosis, in hopes of encouraging others in the CF community, other adults with CF, teenagers, and then parents of CF children, to know that you can still have a future. It requires a lot of sacrifices and prioritizing things, but it's possible. Because one thing I would tell students that I would mentor who are interested in nursing is like, if I can do it, you can do it. So again, thank you to my support system, my husband, my mother-in-law, my stepfather, my uncle, and my countless friends. Thank you for your support, your encouragement. Because oftentimes when I don't have it within to push and move forward, you all pour into me. And again, thank you to my awesome CF team here in Houston, Texas at Baylor College of Medicine. You all rock. But we're all hopeful that for that 10% who are not eligible for Trikafta, we're all hopeful and prayerful that the CF Foundation will soon have modulators for us, and then a cure for us all. I hope you all enjoyed hearing my story. Thank you.
Thank you. I hope it's okay with everybody. I took a quick video of you applauding for her. It'll mean a lot to her, and I know she was really wanting to be here. So we're going to take questions and answers, and there's some great ones in the app, and you can continue to submit them there. But we did ask Braga a few, and I'd like to read her responses. So we asked her, what advice would you give to a person going through a similar situation? She said, I've identified 3 key components that have led me to a place of stability and acceptance. A strong physician-patient relationship. As you heard, her CF team is exceptional, and over the years, they've supported my ambitions while addressing the unique challenges of my condition. As we all know, when you know one person with CF, you know one person with CF, right? So very individualized care. She says managing her CF requires innovative approaches, and together we think outside the box. Her second thing that she identified was support beyond her care team. As she mentioned, her family, her friends, organizations like Compass, and other CFF initiatives have been invaluable. These connections, especially among CF patients of color and adults, help lighten the load. She says she's never faced this journey alone, and having access to support groups and case managers focused on helping families and patients makes a significant difference. And lastly, prioritizing her mental health. She believes that mental wellness is crucial for managing CF. She says, when I am emotionally and mentally stable, she feels that she can handle the exacerbations more effectively. We asked her another question about how do you keep yourself organized between appointments, providers, and balancing family life, and how can your care center help with these challenges? Braga says that she uses calendars to keep track of her appointments and to share information about CF management with my healthcare providers. She says, I enjoy facilitating communication between my specialists, including my PCP and my CF team, to ensure our appointments are effective. Outside of appointments, my family understands the daily challenges I face, so we adapt our plans based on how I'm feeling. So that flexibility is key. In my professional and social life, I give my all when I'm well, but I recognize that some days I can only manage a fraction of that. Lastly, I used to thrive on a busy, productive lifestyle, but therapy has taught me to embrace change and prioritize rest. Maintaining a positive relationship with my care team is essential, and it allows for open discussions about any physical or mental challenges and helps us create a realistic care plan with achievable goals. I'm also learning to be gentler with myself and to appreciate the small milestones along the way. So I'm sure she speaks for many people, but really using her experience to give us some guidance too.
So we can now open it up for any questions for the panel.
Yeah,
So-
let's, there's some in the app.
So while she gets the app, I will, Cameron, one of the questions that we had for you is how do you and the facilities maintain relationships with reps to keep current with the most up-to-date copay cards and coupons?
That's a great question. And I think it probably differs a little bit by institution because everyone's got their rules and who can you meet with and when can you meet with them. But yeah, so we try as much as possible to meet with reps. I think it can get overwhelming because every medicine or every manufacturer has a rep, has an MSL, and what you can get from the two of them is very different, and in many cases, there's a clear line in the sand between them. I have found it's helpful, I know over time, between our pharmacists and our nurse coordinators, we sort of divide and conquer because it's overwhelming to try to meet with Vertex, Zenpep, Creon, Pertzy, right? Like the list, suddenly you have no time to actually see patients. And so it has been helpful at times to prioritize. I know typically myself and the other pharmacist meet with our Vertex folks because that impacts so many patients and now is very complicated. And so we do that. But then some of the other, like the different enzyme programs, maybe I'll meet with someone once just to like put a face with a name, but I'm not always the person who meets every single time. And I think, I think most of our reps and MSLs do a good job of realizing we're all super busy. And so I think over time they get to know us and get to know what we do or don't need from them, and I'm pretty blunt about what I do and don't need from them. There are times where, yeah, like I want to sit with the MSL and go through the latest data, but there are other times where I've read it, I got it, like give me the 5-second version. And so I think being realistic and open with them over time helps them tailor, this is an email update kind of thing versus, hey, we actually should spend some time talking about this. So I think that transparency also really helps.
Perfect, thank you.
We have a lot of great questions in the app, but I'd love to go to an in-person question first.
Hi.
Oh.
Can you hear me? Do you want? I can shout it. You want to shout?
I think we can adapt, yeah.
So I have a question regarding these supplemental assistance programs, and often you hear that people don't want to take advantage of them because they don't want to take away from somebody else who might need it more. And so I know the Health Insurance 2019 data showed that there were issues across income brackets, from those making less than $60,000 a year to those making 6 figures. And some of these programs are income dependent, but how do you have those conversations and encourage people to use these programs that can help them when they feel like they shouldn't take the assistance?
Yeah. Beautiful. You want to?
I can
Yeah.
start.
Yeah.
Yeah, that does come up. So I would say one thing we tell them is, you're eligible for this. You are no less worthy than someone else. And two, in some cases, or really in any cases, there's a case to be made for the more people using this assistance, the more we can be able to go to these states or go back to these programs and say, there's a need. The numbers speak here. These are how many patients need help, and it helps sometimes get more funding in certain states. So the more people taking advantage, it sometimes works out to an advantage to increase that funding because there's a need there. So that's sometimes helpful in helping people wrap their mind around, like, I'm worthy too of this assistance.
Yeah, and the only other thing I would add, I think, especially with the new ability to switch over to premium assistance, that was an unexpected benefit for a lot of folks. And we have definitely had some families be a little hesitant. I think the question comes up, well, if I don't do that and I use less of my, allocated $15,000, could that help another family? And so I think it's helpful for them to realize, like, that $15,000 is allocated to you, and if you don't use it, it's just going to sit there. And then, yes, at the end of your year, it'll get rolled back into the fund, but it is sort of frozen for you or your child or your loved one, and so you may as well use it because they've already planned for you to use it in the grand scheme of things. So that has come up a lot with the switching between treatment or copay and then premium assistance.
And if I can also add into that discussion, I would add that it goes back to what Braga was saying, right? Like, she thought she was okay, and she was okay for a good long time, and now she's not. And that's what these programs are for. And we all pay into these programs. Medicaid, public assistance, Social Security, all of it. All of you pay into these programs. So if you and or your patients have health issues, if you have financial issues such that you are no longer able to do what you used to do, that's what it's for. And let me also add, the moment you don't need it, it's going to stop. So it is available for other people. And the other plug that I would make, particularly for HealthWell, is that HealthWell gets a lot of these funds from these companies that we're using. Vertex, Pulmozyme, all of it. The big pharma is where HealthWell gets its money, and they invest that. So there's no reason for people not to use these programs. And as we were already discussing, the more people use these programs, the more these programs see it, and they change around the benefits.
This is from the chat, and I just want to follow up. It's a good pro tip. So I don't know if you want to remain anonymous, but someone did mention It's good to know that for HealthWell vitamins and the supplements grant, there are pharmacies and organizations that do help patients with the items that require patients to purchase out of pocket and submit, such as MVW Nutritionals, CF Nutritional Support, and Total Care RX. So it is good to know if you are a prescriber or work with a prescriber, you can write the script to those organizations and include all the information, including this patient is applying for the HealthWell grant. So that's important to know. On the same note, here's another question from the chart from a different individual. Do you have thoughts, I believe this is for Compass or Cameron, about how we get information to people with CF about the assistance programs in a way that is not overwhelming and address the application burden which so many report?
Yeah.
Like I'm going to tag onto that because I sometimes have families that don't want to go through HealthWell because they're uncomfortable giving certain personal information.
Yeah.
And so it's a risk-benefit conversation for us too, in addition to the application burden. So.
Yeah. I think, again, this might depend a little on the resources at your center, although with the changes in the care team guidelines, I don't know if anyone else noticed, but the pharmacy community had a little celebration because pharmacists are now part of that core team, and pharmacy technicians, who are infinitely more helpful than me pharmacists, are now part of the programmatic components. So when we think about medication access and just the increasing complexity of all of this, I think really care teams leveraging that to have those resources so that you have someone like me or like my technician, Billy, who I truly cannot live without. I tell her to never leave me. I think having folks who can help navigate that will be really important for every single care center, regardless of size and patient demographic, because we all need help. That's my one soapbox. I think the way that we approach it is really, we do take on a lot of the administrative burden for our patients. We are super fortunate to have a dedicated technician and then 2 pharmacists, so I recognize that is an anomaly. But we typically, what we'll look at is the entry point is sort of, is there a new medicine that we're starting that needs some assistance? So of course, over the last several years, a lot of that has been a modulator. And so our center takes the approach of enrolling everyone into Vertex GPS. I know that is also unusual, but we have had lots of situations for our patients with Medicaid or federal insurance where we have changes in that insurance status. And so we have found it super helpful to be able to call Vertex and say, hey, so-and-so no longer has Medicaid, they need PAP, and they've signed the enrollment, and they're already connected to that resource. So that's a preference of our center. But then we sort of from there take let's deal with the problem that is at hand, and then let's also look holistically at what else they're on and what is this the time where if you're not already enrolled in HealthWell, let's get that done. Do you need a vitamins and supplements grant? Are there copay assistance programs? So we try to use that entry point to then sort of, let's do one holistic look at the whole list. And obviously as pharmacists, we're mostly looking at medicines, but might be an opportunity for pharmacists and social workers to really look at, and what are the equipment costs, what are the co-payments and things like that, and can we be creative with these programs to cover more than just the meds?
I'm going to combine 2 questions for Compass. Couple parts, but how many case managers are at Compass, and how long does it take for case managers to respond to requests, and how long do case managers tend to work with a case? That leading into, do Compass caseworkers follow up with patients to check if if any new issues have come up, such as loss or need or change in insurance?
Okay, so how many case managers do we have? I think there's like 18 to 20, 22? 20 case managers. How long does it take to respond to requests? So we have our phone lines are usually somebody can get through right away and talk to somebody. We don't usually have a hold time. And then as far as responding to that request, there's a lot of things that we can give them a resource for right there over the phone. If it's something that requires a little research or a little it's more complex, we're going to have to call some third parties, some insurance companies. Those can take a little bit longer, and it kind of depends on the response from the insurance. But I would say, like, initially hearing back from a case manager is usually within a day or so, and then if it's not resolved, then usually we at least have like a game plan of what we're going to do, or what we've already started and what we're waiting to hear back on within probably like 3 to 5 days.
Great, and then do you follow up if there's a change, was the other?
So we follow up with them based on like when appropriate, or however long it would be appropriate, like follow up with them on, like, did you get help from this resource? Did you apply? Were there any barriers for the issue that they were calling in? And then that kind of would organically sometimes be like, oh, I actually thought of something else that I need help with. But as far as like insurance changes, or we don't necessarily follow up with them long term, if that makes sense. But we do follow up on the issue that they're calling in for, and then sometimes they have new issues or new questions at that time.
I have a lovely example of Compass helping one of my patients. A young man made a wonderful transition onto our adult team. He was covered by our state Medicaid program and was doing super well on Trikafta, and he was doing so well that he got a promotion at work, and the promotion made him financially ineligible for medical assistance. I was like, wow! And I hooked him up with Compass, and Compass was able to help him get insurance, and also to make application to Pulmozyme Patient Assistance Program. So he's now getting Pulmozyme for free for a year, so that he doesn't have copays or anything of the nature. And then we hooked him up with HealthWell so he could get some of the benefits with his supplements and enzymes. And now he's coming back to clinic, getting on Trikafta. So, and I have to say, the case manager was wonderful. She emailed us both. She asked what she needed from me. She told him what she needed. She followed back up with me saying, I know you sent it on Friday. Did that get done? I mean, she was amazing. So there you have it.
Thank you. Thank you for sharing that.
Another one for Compass. For natural disasters, hurricanes, are there specific case managers familiar with catastrophe resources?
Oh, good question. So not specific case managers. All the case managers receive training on kind of how to triage and identify needs and connect them to disaster resources. Yeah, so we're all trained across the board to be able to respond to those calls and emails.
Looks like we have an in-person question.
This is a little off topic, but I think it's an important cost of living with CF. But someone who works with adults are unable to get life insurance often outside of what is provided by employer. And I'm wondering if this is a topic it's a topic that I rarely hear about at NACFC or other places in the community. I'm wondering if Compass receives calls about this, if you're aware of any advocacy that might be happening as our patients are living longer, healthier lives now on ventilators.
Yeah, that's a good question. We do receive questions about life insurance, and you're right, it is hard if they, outside of like employer life insurance, where they don't do some of that underwriting, it is really hard. And I know our resources are limited too. I'm not aware of advocacy. It's certainly something to give in the NACFC feedback about things you'd like to see next year be addressed in conversation. But I do know we try to refer them to like insurance, like the Department of Insurance specifically. Like there are high risk brokers out there who have knowledge about if you have a pre-existing condition, how to go about navigating life insurance.
I was actually just going to respond a little bit to that. So I used to work with a different disease community, Huntington's disease, and we had the same issue. As soon as you went through genetic testing, which is sometimes 18 years old, you're no longer eligible. We found that working with elder attorneys really early on to start planning, asset planning early on, and even sometimes recommending how to navigate marriage and those things to have access. It's horrific for families that our systems are set up that way, but we found working with elder attorneys who understood the disease and really starting that planning early, and we often would have them at educational days for families so they could start to have that conversation. So sometimes finding some good local resources like that, because we ran into the exact same issues over and over, and then the high-risk brokers were often where we'd end up.
Thank you.
Thank you.
Probably have time for one more question.
Okay.
Kind of along similar lines, this is probably also for Compass. We struggle with patients on Medicare. As far as I'm aware, they are not eligible for many of these programs. They are eligible for HealthWell. Any thoughts on how to help with this population?
Good question. I should also plug that I think there's a session at 2:30 today about where one of my colleagues is going to go more deep into Medicare and the challenges as people are aging into Medicare so they might have higher income or retirement and make them ineligible for some of these things like HealthWell. I will say it's getting easier in 2024 and 2025 specifically, as at least for medication costs with the caps, and they're doing away with the catastrophic. So the medication costs for next year are going to be capped at $2,000, which is extremely helpful, and that can be spread out over the course of the year instead of if they want to do like $200 a month instead of that $2,000 in the first month. So that's life-changing in the sense that there's no longer that 5% for like a modulator every single month, and they've exhausted HealthWell if they're even eligible for that in the first place. But it's definitely on our radar that people on Medicare, especially if you are not eligible for some of those, you're not eligible for a lot of the manufacturer assistance, and sometimes if you're over income, you're not eligible for some of those nonprofits too. So it's definitely on our radar. How do we address this in the community as people are living longer and working and have things like savings and retirement and 401ks and which is great. How do we still address their needs?
Thank you. Good to know there's a session later. Perfect timing.
Yes.
Anybody else have a question? Well, we thank you so much for coming, and hopefully you've learned something. If there are any other questions that pop up, feel free to put them in the app. We can respond offline. The slides are available. There's a handout as well with some of the resources that we could provide, and you can reach out to any of us at any time.
Thank you.
Thank you.